Hello and welcome. I'm your host, Ramesh Kumar, and I'm on a mission to bring value to the healthcare industry through improved transparency. And my goal from this podcast is to give you one aha moment that you can implement in your business, whether you're a TPA, broker, or an employer. In my day job, I run a company called Zaki Point Health that helps self-insured employers and their employees provide transparency, direction, and value by delivering a digital front door for the member that proactively steers them. Please like or share this podcast on your favorite podcasting tool so we can bring together a community of like-minded professionals. This program is brought to you by the Healthcare Administrators Association, HCAA. For over 40 years, HCAA has supported third-party administrators and the self-insured employer industry through educational opportunities from leading industry experts. For information on joining HCAA, please visit our website at hcaa.org.
Today's episode of Voices of Self-Funding is brought to you by WLT Software, a multi-generational family-owned leader in custom claims adjudication and benefit administration. I have personally worked with WLT team and their leadership, an amazing set of people. For nearly 50 years, WLT has empowered innovative TPAs with on-time implementation and seamless partner integrations, driving real savings in our healthcare system. I encourage you to check them out. I am super excited to have Marjorie here in our studio together. And the conversation you've had, Marjorie has a tremendous background in psychotherapy, to mental health, having been a founder of Psych Hub, and many of the things she's done with self-funded employers. This conversation is phenomenal based on Marjorie's depth of understanding, the entrepreneurial energy she brings, and beyond that, the insights she has on where this is going. The three things you're going to take away from this is how to unlock the truth about mental health, because it's not one size that fits all, and she will be able to share with you the different flavors of this. Secondly, you'll also discover where the future of mental and health care is going, how evidence-based practices are going to give rise to tech-driven solutions. And this episode also highlights how to navigate the complexities of mental health benefits and how employers can take responsibility and how they can understand the challenges, navigate this complexity. An amazing, insightful session, so I hope you enjoy it. Marjorie, I'm super excited to have you. You are an amazing speaker, and you'll be speaking later today at HCAA, so looking forward to hearing more. But today I just thought it would be good to dive deeper into your experience, what you've done in mental health, and some of the things that you're seeing, emerging trends. Before we jump into all of that, I'd love to hear, and for our listeners, why should they listen to you? What about your background has driven you to where you are today?
Well, first of all, thank you very much for having me. I don't know if our listeners can see, but we're sitting behind a beautiful kitchen. Yeah. So I really feel like we should be doing a cooking show, or maybe we should create a new version of a podcast where you cook and you talk about your mental health or something like that. But without
hopefully it'll heal us, the kitchen talk.
But without that, I've had a long history in mental health. I like to say I've been in this space my whole life because my father was a psychiatrist. And so I grew up having family meetings on Sunday night. So we would talk about feelings. Yeah, exactly. 4 kids in 6 years and 3 sisters. So there's like a lot of drama. But I went off to college and all my friends joined sororities. I joined the University Crisis Hotline. So I was always interested in mental health, and I went to grad school right out of college. So I have been in this space for quite some time.
Pretty much since birth.
Since birth, yeah. I mean, technically licensed, it was in my later 20s. But I've got the opportunity to work in a lot of different facets. And I talk a lot about, and a big part of my talk today will be that mental health is not one thing. We spend a lot of time using it as an umbrella word, but we wouldn't talk about physical health really as one thing, right? We know that our heart, we would see a cardiologist if we wouldn't go see a cardiologist for a broken foot, right? And mental health, it can show up as subclinical, some stress, some anxiety, but it can be very clinical. It could be depression. It could be complicated grief. It could be an eating disorder. It could be all kinds of things. We're still at a state where we lump it all together. Oh, that person has mental health problems. Maybe people don't even know really what's going on. We've done less diagnostics on the inside as on our mental health as our physical health. I could get into all my different things I've done in the background, but I've done it all from working with at-risk youth at San Diego Children's Hospital, outpatient psychiatry, where I started. I did private practice, where I worked with more all cash pay, more people that could afford to go to private practice. And then I spent many years working with the military. So I got the opportunity to go to the Marine Corps and then build and develop a proactive counseling program for them because they weren't coming in to help really. So it was like, how do we bring it to them, get them help earlier? And then I founded a nonprofit called Psych Armor, which is online education in the military veteran space. And then a little over 5 years ago, I founded a company, Psych Hub, co-founded it with former Congressman Patrick Kennedy, whose cousin right now is making a lot of press right now. Actually, the whole family is making some press right now. Yeah. And then we transitioned it to what I call the next gen CEO. It's amazing. Also in the Boston area. And I always say it's a dream come true when you get to build something from nothing and hand it over. So I was CEO to like a real CEO, like that no joke knows how to do it CEO. It's been amazing. So Patrick and I stay very involved on the board, and as co-founders, we have a weekly co-founder sync with him, but I am now in a new role of executive in residence at SHRM. Okay. So get the opportunity to really dive into workplace mental health. And SHRM it's a human resource association, 340,000 members in 180 countries. They touch 360 million lives. So it's a great opportunity for me to help them with their mental health business strategy.
So tremendous body of knowledge, entrepreneurial innovator. So super excited about our conversation today. We'll dive deeper. But one thing, since you are connected to the RFK connections and Patrick Kennedy, if you had RFK's ear, what would you recommend for the policy changes towards mental health, let's say particularly in the commercial space, if there was any?
Yeah, it's a really good question. I actually am optimistic he's going to be very good for mental health. He is in recovery. He talks openly about it. He does go to 12-step AA programs every day. So he is actively in recovery. And I think those people with lived experience tend to make very good leaders because they understand it. They see the different sides of it, the business case, if you will, the personal case, and then what kind of policy has to be changed. And Patrick Kennedy also is in recovery and a very public person about his recovery. And his father is the late Ted Kennedy. And when Patrick was in Congress and his dad was in the Senate, he had some public things happen for him with addiction, and the family was supportive. And so he's been very supportive of his cousin Bobby. So all of that to say, I'm optimistic. I think mental health parity is the hot conversation, and it's very nuanced. So it's a little bit of a harder answer than a simple one. So mental health parity at its base was created so that people could get mental health care at the same parity as healthcare. Okay. So for example, if you're sick and you go to the doctor and you're not better, you can keep going back to your doctor until you get better. But mental health care tended to be capped, 6 sessions, 8 sessions. So you didn't really have the benefits to keep going back. So at a higher level, the intention was, let's create a habit parity. Yeah. The problem that we have today, so Biden administration was very bullish on parity and put out quite a few rulings right towards the end of the presidency. So it'll be very interesting to see what happens. Part of the problem, and I'm not a parity expert at all, but I know enough to be like a little dangerous. A lot of this onus is going to fall on the employers because what we really have to be looking at is quality of care, not just care, because they're not the same. And not to get too deep into this, but there's a few key things that have to happen to have really quality care. And when we have that, we will have parity. And then those policies can be enforced. But we have to fix a few things first. So one of them is this concept of evidence-based interventions or evidence-based treatments. And we have that in all of healthcare. But people don't realize how important they are in mental health care. So going back to my mental health isn't one thing. If someone, let's just say, has an eating disorder or OCD, that's a really good one, obsessive compulsive disorder, there is an evidence-based intervention called ERP and exposure response something. When it's used, that consumer, patient, client, whatever you want to call it, going to that treatment, has a 70 to 80% success rate.
Okay. If they have to follow this particular protocol.
Exactly.
Okay.
If they are just seen by a generalist, which most mental health therapists like myself, that's what we are, the rates are very, very low. They can be under 10%.
Okay.
But we have those in every single pretty much area of mental health. Now, cognitive behavioral therapy is a good catch-all and works really well. A lot of people still do talk therapy. There's really no evidence that it works. In fact, in a lot of cases, it causes problems because we go back in our past and we don't tend to relive things quite the same as they were. Complicated grief, talk therapy does help. So there's some things, but it's really important that we train up, which is what PsychHub does, providers upskill them into these evidence-based interventions and that they start using them. The next piece to that, and these are all of our like little mental health buzzwords, is measurement-based care. And that's a big kind of topical thing right now. And what that means is that that provider is actually measuring how that client is doing. So if that client isn't doing well, they're able to try a different intervention. So you really have to then be using evidence-based care. You have to measure that care. And then we can get to value-based contracts or value-based arrangements, which we hear so much about in healthcare. We have a really hard time doing that right now because who wants to take risk on these populations? But when you actually do measure the care and you use evidence-based care, the outcomes are actually really high and there is a value, a business case on it. So when all of that happens, then you can have true parity. So I hope to answer your question in a very, very long-winded way.
No, but this is very helpful. So that's kind of the issue. And are you saying it's not really followed, evidence-based care and measurements? Is that not really like 10% of the mental health professionals are following it?
It's a great question. It's probably about 10%. It's going to get better, and it is getting better, believe it or not, because of all the private equity and VC investments that have been put in mental health. It's actually benefiting mental health in some meaningful ways because they're investing in what we call aggregators. Like you see this roll-ups. You see it in everything. Dermatology, right? Where they go in and in mental health, we call them the single shingles, right? You have your old psychologist, marriage family therapist, a little awning out on the corner, and it's right there, single shingles on the road. Now these VC-backed companies and private equity, these aggregators, and there's quite a few of them now, they are bringing them all in and they're aggregating them and they're taking care of the back office and they're providing them all these tools. Well, they also care about making money. And so your single shingle provider, this is like going to be a little controversial, but you get reimbursed for having what we call butts and seats, right?
Yeah.
So now you have a client comes in every Tuesday at 10 o'clock. Now as your client's getting better, you have an opening 10 o'clock on Tuesday, and you have to go find the person that, has a symptom that you feel comfortable treating, has the schedule that has that time. I mean, it's not as easy. Sometimes it's easier to keep that person. Maybe they come every other week, but that happens. But when it's about the money, now all of a sudden it's like, let's get the volume through and let's show our value prop because now we can pay provider. Like there's ways to make more money. Okay. So it is getting better. Last Friday, literally just last week, JAMA released a study that $100 of investment for employers in mental health reaped $180 in benefits. And when you drill down on it, it was done with Spring Health, which is one of these kind of EAP sort of replacements that it's all inclusive, does it all. Mm-hmm. And they use measurement-based care and evidence-based interventions. So that was a big part of it, was that they were actually seeing the episode of care was a little higher, but the sessions were a lot less. And people were getting symptom reduction, and then they were seeing a relationship with physical health, right? I didn't realize this till I was reading that, about 50% of high cost health conditions come with a mental health load of a mental health diagnosis.
And it's not really being diagnosed as well because in our healthcare system, people don't really do this mental health kind of evaluation. So people are a lot more focused on the chronic conditions, but as you're saying, most of them have some element of.
Well, we all do to some extent, right?
Yeah, but you all have blockers.
Yeah.
Yeah.
To the point of it being an expensive problem if you don't, even medication adherence, right? There's a lot of that. So I'm actually pretty optimistic that number is going to continue to go higher. It has to, because the success rate, I think the older population people like me, right? Like I don't practice anymore, but if I did, I would be resistant to change. I'm being honest, right? It's going to be those that are probably younger, might have been trained more in interventions. We didn't learn it when I was in grad school. Like we do now. So I'm optimistic, but there's a long way to go how mental health care gets better. And then all the policies.
So then let's switch it from the employer lens. This kind of knowledge, what should the employers be doing? Are they expecting contracts to be written with evaluation-based and measurement-based? You've done a lot of work with Psych Hub itself, but what should they be doing?
Yeah, it's a really good question because I'm pretty convinced employers really want to do the right thing. We're no longer in this place. I'm going to do something in my talk today about where we were, where we are, and where we're going. Stigma's gone. Most people are pretty comfortable talking about mental health. Benefits, I mean, every time I turn around, like I said, I'm in this space every day. There's a new mental health company. I can't keep track of like, and they all have some variation of the word mind or head in them. And they all just, to me, start to sound the same. So there's no shortage of benefits. And these benefit, the people that are helping choose these benefits, they really do care. Like I've spent a lot of time with them. They really take the time and they get to know. So I think the issue isn't a lack of benefits. It isn't a lack of understanding the business case for the employer, because I think they get it, even just at the basic presenteeism, absenteeism, all of that. The issue is really navigation. It's very confusing, for an employee to know how to navigate all these different benefits now. You've got Talkspace, and you've got an EAP, and you've got this access to your insurance, which you could go to one of these aggregators, Headway or Alma or Grow, or there's a whole bunch of them, right? Or maybe you have a virtual physical health partner that also does mental health. And then SHRM has done some research that shows that 50% of employees don't want to go to their employer to get mental health benefits.
Yeah.
So I think the issue, in my opinion, is twofold. It's screening effectively and it's navigating, because you can navigate someone to care, but most people don't know what they need. Going back to mental health isn't one thing, and going back to the need for people to get evidence-based care, most people know they're not feeling right, or someone that's close to them is telling them you got to go get help, and they don't know what they need. Not to throw myself a little self-plug here, but I have been working on a new business, and we've created a very, very robust assessment. It's called Balance, behavioral assessment of lifestyle, anxiety, needs, coping, and environment. And it has 36.
Great acronym.
I know. ChatGPT came up with it to give it the credit. On the back end, it's like 36 to 38 different validated assessments on the back end. It takes 30 to 45 minutes. Not a quick one at all. It's really meant to be an in-depth look at what's going on with you. And it looks at everything from anxiety, depression, your typical things, alcohol, substance. It looks at loneliness. It looks at work-life balance, burnout, but things like financial stress, caregiving stress, compassion fatigue. Are you worried about your kids, or this or that? And it's all confidential. When you're taking it, it's all adaptive, meaning that you're only getting asked questions based off of how you're answering questions. So if you say you don't drink, you're not going to get those questions. So it depends on how many questions you get. And immediately when it's done, it gives you a report that and the report can be 30 pages, but the front page is a whole dashboard of these 30. I say the number is big because if you're a female, you get postpartum, maybe, or menopause. Like not everybody gets the same, but let's just say it's in the high 30s. It gives you a dashboard of kind of green, yellow, red, mild, moderate, severe on all of these things, with the idea to help you kind of see you're doing great in all these areas. This is what you need to focus on. And then telling you what those interventions are, and then telling you what your employee benefits, where you should be going for that intervention, so that we bypass having to go to the benefits team, get higher engagement of the benefits already.
So in some ways, this screening diagnostic approach is to really match what kind of specific mental health program or service you really need, and being able to find within that the right kind of mental health provider.
Yeah, that's exactly right. Because There are so many benefits. Like I've been with Sherm working with a lot of companies now, and they say, I don't know if we have adequate, benefits. And I'm like, I bet you do. Mm-hmm. And sometimes they don't even realize with their Aetna or their Elevance or their United that they have access to all of these specialty groups now.
Yeah.
Like I said, now post-COVID, we have all this private equity investment. We have eating disorder ones. We have OCD ones. There are all of these specialty groups that have popped up, and most of them are in network. So people don't realize really what they have access to. They just don't know that that's what they need. Or they don't know how to navigate.
And so that's kind of the next level of paradigm shift here. People understand the value of all of these things. There's no stigma. Diagnosing, screening better, matching people to the right kind of programs and services. Maybe tell us a little bit more through some of the case studies. Where have you seen you talked a little bit about the $100 to $180 benefit, but what are some of the kind of benefits you've seen when proper care has been given? What are some of the employers seeing the outcomes of that? And then what are they seeking in order to really do more of this across the board?
Yeah, it's probably similar in physical health, but maybe not exactly, in that it's not a one size fits all. So what happens is people need different things at different stages of their life. And those stages could be weeks, months, years, right? It's a little harder to say this is the case study that really works. What we find is, no surprise, the earlier you get to care, the better your outcomes are, right? So there's Mental Health America has a saying, which is before stage 4. Like you wouldn't want to go to get cancer treatment at stage 4, right? So prevention is a really big piece of this, and like healthcare, right? But that prevention looks different for different people. So what we're seeing is working really well is maybe traditional therapy augmented by AI and some of these other that are more up and coming technologies that can be a chat bot to help you in between your sessions. Think about if you have a 45, 50-minute session every other week, not a lot of time. But if you have a AI coach that's kind of helping you, I mean, it's really cool to see some of this technology. So I'm not one that thinks AI is going to replace therapy, but I'm also not one that's saying therapy is the end all be all. So I feel like it's this combination of this hybrid approach based off of what you need. When you need a lot, maybe you need residential and you need to go in network. And if you catch something early, maybe it's just an AI or maybe it's a hybrid of both. And so employers, what we're finding is the ones that are doing it and having the most success with it are open to the spectrum of employees need different things and their families need different things. And the reality is that if you're an employee and you're married and your spouse is going through a hard time, it is absolutely going to affect the way you show up to work every day. Or if you have a child who is having struggles. And so you can't separate out basically what they're doing from what your employee is doing. So employers are having to worry a little bit, more now about taking care of the whole family.
So then how would a smaller employer really deal with this complexity, the range of mental health programs out there, whether that's AI, hybrid-driven stuff to coaching to anxiety and medication? So how should they navigate all of this? They can't do.
That's my favorite question. I love it. I think about that all the time because we always look at the big companies.
Yeah.
And the reality is they can do things that the small to medium ones can't.
Yeah.
So like that report I mentioned in JAMA with Spring, like Spring and Lear are having really good results, but they're very expensive. And the small and mid-sized companies really can't afford that. But the part that is, it's frustrating, but it's also good, is that everyday health insurance, like I'm saying, Aetna, Elevance, like the big ones, they now have in their portfolio all of these resources. And you won't believe one of the biggest challenges these, I call them startups, some of them are further along than others. Their biggest challenge they have, everyone thinks it's a provider shortage. Like we don't have enough providers.
Yeah.
It's not a provider shortage. It's the client. It's the patient. It's patient acquisition is where they are struggling. They don't have the volume to treat. So it's really these small and medium companies, if they have even just commercial insurance, they have a lot of benefits. They just don't know how to navigate that. The larger companies have these care navigators and they help them. The small to medium ones don't always have that. So it's a navigation issue and utilization, really.
So you're kind of saying all of them pretty much have access.
They do.
Even if they have all of these, like
special kind of small PPO networks. So they're not on Cigna, but they're working with the TPA, for example. They probably have some of these through their network provider.
I have yet to find one that doesn't have adequate coverage. That's not the problem. The problem for the employee is they go out and find care, and I don't know if you've ever done it, but I feel like everyone has the story either for themselves or someone they care about or that they cared for. It is so hard to find care. You go onto these websites and you get a roster. We have this whole thing about ghost networks. That's all true. And you call one after another, after another, after another, after another, and they don't answer.
Yeah.
And part of it because they're the single shingles. And those single shingles don't really want to take insurance because they figured out they don't really need to, fair, and they can make a lot more money if they do it on their own. That's where this whole confusion rub comes in, because these aggregators, I don't really know what to call them, roll-ups, but they are all of your new private equity VC investments that you hear about in mental health. That's very different because they're actually getting you in 24 hours and they're screening you and they're trying to get you to the right place and the right provider, and they're investing in psychiatrists, a lot of them. They're investing in evidence-based care for all those reasons I talked about.
Okay.
So the field is going to change, and eventually those single shingles are going to, I don't want to say like age out, because we see it in healthcare, right?
Yeah.
I mean, wouldn't we still have that primary care internist that's on the corner?
Yeah, they either sold their practices or they kind of retired, or and so yeah, seeing that these new age VC backed, these bigger kind of aggregators are really providing a lot of value.
Yes.
They can serve things better for the right individuals with the right kind of intervention. And then the navigation challenge is really where I guess in some ways PsychHub also comes in.
It's true. I mean, people always ask me, like, what are you doing? I have the hardest time with them. I don't know what sometimes I have to say I'm in mental health because I just I feel like I'm like Forrest Gump. Like when I walk through my background, I sound so like all over the place, but I love to think about solutions to big problems, right?
Yeah.
So PsychHub really has just been so much fun. Patrick and I built it to do really two things and then bring it together. One was to train consumers on evidence-based practice, and the other was to upskill the providers on using these evidence-based practices, right? Because you could upskill providers all day long, but if the consumer, that's what I call patients, clients, or because I don't really like to use patients for mental health, right? So if a consumer doesn't know what to ask for, right? So and then our idea was to always build a marketplace to bring our consumers to our providers. In this process, we've done a very good job at getting providers onto our platform. We've made huge progress in Medicaid, and we're pretty much written in all the Medicaid bids. So we don't really care if Elevance or Aetna or whoever wins it. For the most part, we're going to get that business. So we've done very well in that, and then a lot of these aggregator groups. And we've also done really well with consumers. So I say my little humble brag is, if you go into YouTube and you put in a mental health topic, chances are a PsychHub video is going to come up because we get millions of views a month there. So we wanted to bring them together, and we brought in our new CEO who was on the founding team of Care.com and worked there, built that up for 15 years or something. That's why Boston made that.
Yeah.
And he has the perfect background to have built the PsychHub, where people can come, they can take a brief assessment, whereas Balance is 30 to 45 minutes. This is 30 to probably 45 seconds, like a minute or something. But it really does help you quickly see what you need. And then it's kind
of a lot of educational content after that.
There's a ton of educational content because we've got lots of it. And then it is similar to a kind of a ZocDoc where it helps you get to that provider. Yeah. So at scale, PsychHub is doing this kind of how do you connect people to, especially in network care.
So this is really, really helpful for us as listeners. The challenge that you highlighted around navigation and around really working not with single shingles, but more with these aggregators so you can serve the population better, and then educating the consumer and maybe even diagnosing the problem. Those are 4 areas I heard a lot. If you had to kind of provide some direction to the TPAs who are listening to this, or self-funded employers, mid-market, what steps should they take next?
Well, first of all, I just really have to compliment you on how succinct you just did that, summary. It took me, how long have we been doing this now? And you just, and so it shows me, A, you're actually listening, but you just did such a good job of putting it in a very concise framework. I think when it comes to the TPAs, they play a really, really important role. And I think it's understanding the business case, which I'm going to talk about today, really understanding the why of the business case, understanding to hold the thread on evidence-based care, because a lot of providers will say they use it, but that doesn't mean they do. If they're not measuring it, if you think about in physical health, maybe like I was telling you, I had this ulcer on my cornea. Well, when I go to the ophthalmologist, he puts the thing in and he looks in it and he can see if it's getting better or not. Like if we're not measuring something, you can say all day long, or a lot of, I used to do this, so I get it. We have our own theoretical orientation. It's eclectic that we've accumulated throughout the years, and it doesn't really work, but it's what we're comfortable with. So I think they need to understand the questions to ask and to hold the providers or the provider group accountable for the care and the access, right? Like it's going to be really important. How quick can you get somebody in? Because when people need help and they're ready to go, you want to get them in. Do they have what I mentioned earlier, a more integrated approach, meaning that in a lot of these new startups too, it's really cool. They have these apps, or they have biofeedback things, or they have AI chats. Do they have things in between sessions to help somebody?
To connect with the
That's
patient,
right.
To the consumer.
Yep, they're going to do much better in care. So I think the TPAs, the plan administrators, and I'm still trying to figure out the difference between the two. I get it a little bit confused, but more that they understand that it doesn't matter really if you go with ABC company or DEF, like as long as they are committed to getting that person in, delivering evidence-based care, measuring it, and they make it easier for the provider. Things like the scheduling and providing, are they doing virtual? All of that, then they don't have to worry about quantity. They don't need in their portfolio, if you will. A few of these, knowing the difference. The other thing I think I'll mention is the continuum. I can't remember if I said this, of like kind of subclinical all the way to extreme. That is really important because things like, just going to digress for 1 second. One of the issues that we're having, and this is definitely affecting TPAs and really employers as well, is it used to be, and I think we've talked about this before, but it used to be that we would go through life transitions and know that you're going through a hard time and it's okay, you're going to get through it. And I think what's happening now is we're pathologizing everything. So things that may be typical and not out of the ordinary grief. And when I say grief, I don't just mean when someone dies. I mean, you go through a divorce, you send your kid off to college, you lost your dog, like things that really matter and are transitions. You're in a bad breakup. Those kinds of things affect how you show up at work. And we're pathologizing them, meaning we're giving people diagnosis. We're saying very quickly, oh, you're depressed. You need to go on meds. You need to go to the doctor. You have to get help. And some of them, just getting some good transition care is really all we need. We have a lot of over medication right now. And so I think that's also really important. I think this education for them to understand on that continuum, what is sort of just normal transition, and in 6 to 9 months, it's trite, this too shall pass. Like they will overcome it. We're pretty resilient people. So I think understanding some of those
range
things.
of the spectrum of things, the clinical, you've got some issues with medication, you've got some anxiety, but all the way, just when you describe the transition care, it's more like a mental health coaching.
It is.
For like a 6-month period.
It's like we had back in the day, like when I was training, Elizabeth Kubler-Ross was like the first one to do the stages of grief. And now they're saying those stages aren't as concrete. You don't actually go from one to the other, but all of it is in the right form of, we go through stages and they may not be so black and white, but we've all been through it. It's you're bargaining, I would do anything to make this better again. You're pleading, you get angry. I don't remember all of them. We all go through that. So I think psychoeducation key. If you know some of that, you can get help. I'm not saying don't get help, but like they don't need this high level of care. So I think benefit administrators, CPAs, like they need to understand this spectrum.
Yes, very key. This is very important concept. We should have a diagram for that. In fact, publish a book almost, I think. Maybe we could do another podcast. The spectrum here.
You can tell I like to talk.
Yeah, this is really good. One last question. Take a 1,000-employee self-funded employer who's spending about $14 million on their healthcare benefits. What portion of that should be diverted towards mental health?
Wow.
Help us put this into context.
Well, it's a great question. I don't have an answer because I'm newer into this workplace, thanks to SHRM. I'm like a sponge there. And it's just this incredible machine of so many different things. And I'm just like, every day I'm learning more and more. But I do think on that, how much should be spent. I really think when it comes to mental health, a decent portion should be spent on education, coaching, and earlier. So, that old adage, an ounce of prevention is worth a pound. I think we've seen it. We know the business case again and again and again. Problem is, people learn differently. You said to me before we started, I love listening to podcasts. If you like to learn by listening, then that's what we should be investing in, right? If some people like to watch videos, if some people like to read, the more we can explain to people what's going to happen, when it happens, they handle it much better. So I would love to answer your question with a dollar amount, or a percentage, and I don't know it. But what I do think is that a large percentage needs to be on the proactive side rather than the reactive side, with the goal of not always having to get.
And which could be a lot cheaper, because if you educate early enough, you have the content available to help people see the spectrum, what they need, and help them navigate better. Then you don't really need to overspend on the service itself.
That's exactly. And so if we keep focusing on the reactive service itself and someone's in a chronic state, it's so cost prohibitive. The ripple effect is so huge. It's like the model of suicide I was just reading a couple weeks ago, this suicide prevention programs and companies. The amount of people that actually complete suicide is actually fairly low, but the ripple effect of when there is a suicide is really high, right? All these people are impacted. So companies are willing to make this investment in training up people, right? But we should be doing that with everything. Think about it, Ramesh. I'm really obsessed right now with climate and what's happening with the environment. And I grew up in LA. I have a lot of friends and family that were impacted by the fires or the hurricanes in North Carolina, Florida. You better believe when someone is either evacuated or they lost their house or all of those things, it affects a lot of things. And that's where I'm very focused right now, is on trauma, both on the macro level, on the micro level, and how do we prepare people better for that, and then how do we respond better for that?
Yeah. There's so many, we have to do a follow-up. Where can people go to get in touch with you?
Probably the easiest way is my email is mm@marjoriemorrison.com. So M for Marjorie, M for Morrison, mm@marjoriemorrison.com, or on LinkedIn, Marjorie Morrison. And I would love to chat. And I'm learning from everyone. So.
Well, this has been fantastic. And thank you very much for taking the time.
Thank you for having me.
Insights for our listeners.
Thank you.
Please join us again for another podcast in the series brought to you by HCAA's Voices of Self-Funding. Please like and share so we can build a community of like-minded people. And tell us about topics that we should bring to you next. Please watch your email for updates and upcoming guests. I'm your host, Ramesh Kumar of Saki Point Health.